trial, the CONSERVE trial, direct catheterization versus selective catheterization guided by coronary computed tomography in patients with stable suspected coronary artery disease. This study is coming from South Korea, from Seoul, and Dr. Chang will present. Dr. Chang, please.
Thank you, Mr. Chairman. It is my pleasure to present the CONSERVE trial here in Rome at ESC late breaking. I have nothing to declare. We started at the rationale first. Nearly 2/3 of patients undergoing invasive coronary angiography have no obstructive disease. Second, coronary CT angiography is a non-invasive test with high performance to exclude obstructive CAD. However, for patient referred for invasive coronary angiography, whether selective ICA informed by coronary CT angiography is effective is unknown so far. CONSERVE trial was designed aimed to determine the clinical and economic outcomes of selective catheterization as informed by coronary CT angiography versus direct catheterization for stable patient referred for ICA. CONSERVE trial was designed as a prospective, open-label, randomized controlled trial. Stable patient with suspected CAD but without known CAD referred to ACC/AHA Class II guideline indicated non-emergent invasive coronary angiography. At the point of considering ICA, were randomized either direct catheterization strategy or selective catheterization strategy. Downstream clinical decision-making were at sole discretion of their caring physician. This is the result. Primary endpoint is clinical. MACE rate is not different between two groups. Direct invasive angiography MACE rate is 4.6%. Selective invasive angiography MACE rate is 4.6%. Hazard ratio for MACE p-value was 0.99. Individual component of MACE, non-fatal MI, unstable angina, urgent emergent revascularization, all the components of MACE were not different between strategies. This is second endpoint. Second endpoint is economic. In per patient ICA utilization, direct ICA was 0.02. Selective ICA strategy was 0.22. The selective ICA, that means selective ICA strategy can reduce 78% of invasive angiography utilization. Revascularization, direct ICA 0.17, selective ICA is 0.10. That means by selective ICA strategy, we can reduce 41% of revascularization. Non-invasive testing is higher in selective ICA strategy, but when we exclude index CT angiography, downstream non-invasive testing not different between strategies. Cardiovascular hospitalization were not different, but outpatient visit resource utilization is higher in direct invasive angiography strategy. As a result, cumulative cardiovascular cost is $6,600 versus $3,300. That means by selective ICA strategy, we can reduce 50% in cost. Compared to direct invasive angiography, selective invasive angiography demonstrated no difference in MACE, lower rate of invasive angiography, and revascularization, lower cardiovascular cost. In conclusion, for ACC/AHA guideline indicated invasive coronary angiography, selective invasive angiography informed by non-invasive coronary CT angiography were associated no difference in outcome, while reducing invasive coronary angiography by nearly 80%. Thank you very much.
Thank you very much, Dr. Chang. So we have now a few minutes for questions from the press. Please, when you ask the question, identify yourself and then ask the question. So please, any questions for Dr. Chang? Please, can we have a microphone for the lady over there? Could you please, third row there on the right?
Hi, Shelley Wood with TCTMD. On the basis of these results, are you changing your strategy at your clinic? Are you pre-screening now or not so much?
Pardon?
Slower, sorry.
Yeah.
Are you now, with suspected CAD patients, are you now pre-screening? Have you changed your strategy based on these results?
Yeah. This study, for example, the all other study, the published by so far is compare the value of CT angiography with stress test or conventional modality. But this is when we considering the invasive angiography just at the front of your cath lab. Once you perform the coronary and invasive study, we can reduce the unnecessary invasive angiography procedure. It definitely changed our routine daily practice.
But given all the tests that are available in patients who show up with chest pain or problems, what is the best series of tests that you would do? You mentioned stress testing, CT.
In this study, the 2/3 of patients, the ICA referral indication was 2/3 of patients symptom-based, and 1/3 of patients the non-invasive stress test result, mainly from exercise. So this is adhered to current our ACC/AHA guideline procedure. So whatever non-invasive study or whatever symptom patient have, it is when you consider the invasive angiography as a final step of diagnostic workup, this is coronary CT angiography as used as a gatekeeper.
I understand. Thank you.
Thank you very much. Any other question, please?
Perhaps I could get a comment from the panel, though, in response to that. Does that make sense?
I would rather stick to the presentations. We're very strict on time. We will have time for discussion and some questions after we finish the press conference.
It's actually quite standard to get a comment from all of you on the panel. If we could do it briefly.
Well, I think any of these results naturally have to be included in our reasoning, and if the question regards potential implications in guidelines, of course the information needs to be more matured, and you have to have additional data that can validate some of these results. But certainly, this will be incorporated into the reasoning when you dealing with these patients. I think it's important, mostly for the cost reduction, which is something that, as we all know, it's very, very relevant, but still needs to be integrated in a more mature way, I would say. But I saw one hand raising here, please.
Mitchell Zola, Cardiology News. So if I understand it correctly, then you do the CT angiography, and if you see a 50% or greater stenosis, then you do a catheterization. Is that correct?
We do not mandate any downstream procedure to site physician. once they perform the index test in ICA group invasive angiography, the selective referral CT angiography, once perform the index test, all the downstream clinical decision making is at the sole discretion of site physician. Yeah.
So the only thing that was specified is you told the interventionalist to do the CT and then use your discretion on what to do next.
Yeah, yeah,
And just inserting that step.
yeah, yeah.
led
Just
to
inserting that
yeah.
step prior to cath lab.
And so up until now, CT has not been used in this way until you did this study, is that correct?
Pardon?
That CT angiography used specifically in this way has not been previously studied.
Right, right.
Okay, if no further questions, thank you very much, Dr. Chang.